My topic for today is going to be unilateral disc edema. Well, I'll be focusing more on arthritic and non-arthritic. I have no financial disclosures to make. Before I move on, I'd like to differentiate any unilateral disc edema on the basis of the visual loss into three categories: if there is no visual loss, if there's acute visual loss, and insidious visual loss. So in a case where there's a unilateral disc edema and you don't have any visual loss, we look at three possibilities. One, it could be a pseudo papilledema or an early papilledema, as Dr. B.V. Rao and Dr. Nikhil have emphasized. It could be diabetic papillopathy or a CRVO in the early stages without macular involvement. It could be an acute visual loss where we can either have optic neuritis, ischemic optic neuropathy, or Leber's hereditary optic neuropathy. Optic neuritis, Dr. BVR has beautifully described, and I will be focusing more on the ischemic aspect. Insidious or a progressing visual loss where we come across compressive optic neuropathy or infiltrative optic neuropathy. This also includes conditions like intraocular diseases where there could be uveitis or severe hypotony following glaucoma surgeries, where they can have the similar kind of disc edema with progressive visual loss. What's important is a very thorough workup before we go on to any case of analyzing or managing a case of disc edema. And it starts with a very good history. As it's important, age and gender also play an important role. Like for example, if you're looking at a disc edema in young individual, we should keep optic neuritis in mind, and later it's more of ischemic. Gender, as we know, it's 75% females with disc edema in early age usually would have optic neuritis. Then a very thorough history about whether the patient has any systemic or neurological diseases, an associated family history. Medication is important, specifically if you are looking at patients on very severe hypertensives who are on treatment and could have nocturnal hypertension, which I'll describe why, and also conditions other individuals who are on amiodarone. Then ocular history is important, basically visual loss, the rapidity of onset, the chronicity, whether it's intermittent or constant, then pain, not just pain but pain associated with eye movement, any diplopia, jaw claudication, scalp tenderness, etc. An examination again, very important, starting with visual acuity. As I said, we can differentiate on the basis of whether the vision loss is there or not. Then color vision, it's important because certain conditions, like as Dr. Venkat said, that color vision in case of optic neuritis is much more and does not correlate with visual loss, unlike ischemic optic neuropathy. Then we have to look at contrast sensitivity, pupillary reaction, very important, because if the patient has an relative afferent pupillary defect, then we know for sure it's an optic disc pathology. Then optic disc appearance fundus, and then visual fields. So basically moving on to the actual topic, that is ischemic optic neuropathy, is the second most common cause of permanent visual loss, and we differentiate them into non-arthritic ischemic optic neuropathy, perioperative, and arthritic. Now let's look at this. This is a patient who had non-arthritic ischemic optic neuropathy. Now this is seen commonly in individuals between 55 to 70 years of age. It's painless, and the patient can have anywhere blurred vision, central vision from 6/6 to no PL. In case of unilateral cases, definitely there will be a relative afferent pupillary defect. Classical appearance of the disc could be from diffuse edema, which is seen about 70% to focal edema, and could have sectoral involvement, as is seen down. The other important feature of NAION is something called luxury perfusion, which means that the normal part of the optic disc in case of sectoral edema is hyperemic. So hyperemic normal aspect is called as luxury perfusion. The other thing is basically we have to look at the fellow disc. Now this is another case where you can see a few of exudates, flame-shaped hemorrhages, there is disc edema. And this is a classical thing which Dr. Nikhil also emphasized, that the fellow disc, if it is a small disc with no cup, a very small cup, then they are at more risk of developing NAION subsequently. And there's about 1/3 of these patients develop it. Then visual field changes could be common as being altitudinal. It doesn't mean that it can only present in this form. There could be variable ways of presentation, but commonness is altitudinal and mostly inferonasal. But arcuate central scotoma also can coexist. Most important is to find out associations, commonest being hypertension, followed by diabetes mellitus. Do a good workup to rule out any lipid abnormalities, like a lipid profile is a must, and look for hypercholesterolemia. This could be at any age. But in middle age, specifically rule out any ischemic heart disease and prothrombic risk factors like homocystinemia or antiphospholipid antibody syndrome. Before we move on, I'll just quickly touch upon what is diabetic papillopathy. Basically, this is seen in individuals who have diabetes and usually bilateral, but are seen in those with chronic IDDM or NIDDM having more than 10 years of the disease. The age could be anywhere between 20 to 80. But mostly, as I said earlier, it could be asymptomatic and visual activity is only mildly deranged. So the disc could be anywhere from normal to edema with telengiectatic vessels. But there is no NVD in this case. We are not talking about NPDR or PDR. So in this case, it's only the disc edema. And visual fields will show either an enlarged blind spot or ocular defect. But good part of this is it has very good prognosis. So in certain conditions, we need to wait over time to actually go back and find out the cause. Like a diabetic papillopathy, over 3 months will resolve completely and the vision will improve. And hence, hindsight, we can say this patient had a diabetic papillopathy. Now coming back to NAION and hyperhomocysteine, it is seen that between 7 to 45% of different studies show that patients with NAION in young individuals actually have high levels of homocysteine. And therefore it's query a potent atherogenic agent which is responsible for developing NAION. Studies have shown that for every 5 micromole per liter increased levels, there's an increased risk of developing vascular occlusive disease in males and females. And this could mean myocardial infarction, stroke, and NAION. They could also be CRVO, CRVO. So any patient, young patient, if you think of it, do a serum homocysteine levels to find out the problem. Exact mechanism of why this happens we don't know, but studies have shown that when we give certain vitamins to these patients, like we give vitamin B6 and B12, the plasma homocysteine level drops and actually it improves. In fact, studies have also shown that per se giving vitamins in this levels can to some extent protect them from vascular disease. Obviously, there's nothing concretely confirmed. Now, other associations which can also lead to NAION is basically anemia, which could be non-surgical. In case of surgical, I mean acute blood loss, but otherwise non-surgical would mean dialysis, epistaxis. In this case, you need to treat the hematocrit values. Second is hypotension, which is a very important thing. Non-surgical and nocturnal hypertension is very important. So a patient who is an NAION, rather than doing a lot of studies, investigations like Doppler, 2D echo, a 24 hours blood BP monitoring would be a better option, and look for the drop in the nocturnal blood pressure, which is very important, and that is found to be the cause for developing NAION. Then other association is sleep apnea syndromes. You need to specifically ask the person for any insomnia or snoring, and they found that there is 71% association, a study which was done against the control group. Then drug induced also, wherever there is a possibility of developing hypertension, can also have development of NAION. We have seen that patients who develop NAION do improve spontaneously, but there is not much improvement in the visual fields. The acuity is more likely to improve. Eventually, there is optic disc atrophy set in, as you can see here, and then you can see some amount of sclerosis of the blood vessels. There is obviously an increased risk for cardiovascular events, and therefore we need to monitor them and find out in those cases, intervene and treat the actual pathology. It is seen that recurrence in the same eye is seen in about 6% over 5 years. The risk of other eye is between 15% within 5 years, specifically if there is a disc at risk. If we are looking at the FFA features, this is more so for arteritic. We see there is a delay or incomplete filling of the peripapillary choroid. I mean, in this, after 18 seconds it actually started filling up, and it should happen in the early 10 to 11 seconds. Also, there's a delay in the prelaminar optic disc filling. What basically classical feature you get is first there's a hyperperfusion followed by a hyperperfusion, and finally there is a sectoral involvement as seen here, which indicates that this patient could have a arteritic, and this should be done within 3 weeks of the actual event. As you see here, that this is the actual appearance of the disc, and here you will see the sectoral involvement. Now there have been a lot of treatments, options done. Corticosteroids have been tried, but it is nothing concrete, not that it really helps, so there is no clear data about what to treat. But there had been one study where they had used optic nerve sheet decompression for patients with ischemic optic neuropathy. At the end of the study, they realized that there are patients who underwent this actually had more loss than it actually benefited, because those without treatment alone were improving on its own. So basically there is no effective treatment, only that you need to control the risk factors once you've done an investigation like hypertension, blood pressure, hypercholesterol, etc., and minimize the nocturnal hypotension. Then coming to the important aspect of differentiating it from optic neuritis, Dr. Venkat has told very clearly, but just to show that in case of age-related, we see that young patients have demyelinating. Pain is more common in demyelinating. The classically disc swollen is seen in ischemic, whereas in demyelinating, it's more of is less common to have a disc swelling. It's more of a retrobulbar. Arterial attenuation is common in ischemic. Altitudinal visual defects are more in ischemic, commonest being inferior. In demyelinating, you generally have a central scotoma. Sectoral disc edema is commoner superiorly in ischemic, whereas it's rare in demyelinating. Hemorrhages are common in ischemic. Association, as we know, vascular disease for ischemic and multiple sclerosis with demyelinating. Treatment-wise, there is none for ischemic. Steroids, as we know, for demyelinating. But prognosis-wise, demyelinating is obviously having good prognosis. Now coming to the second thing is perioperative AION. This is usually bilateral. Commonest causes being anemia, hypotension and overhydration. Though it's rare, less than 0.1%, we see that a lot of patients undergoing cardiac surgery, back surgery usually have developed perioperative AION. Improvement is rare, but you need to correct the factors. Coming to AION, which is basically temporal arteritis, it's seen over 70 years and more in female. Here there's no eye pain, but patient would have headache, scalp tenderness, myalgias, etc. Most important event is transient visual loss or TIAs. If you suspect a TIA with an arteritic and appearance of a disc edema, think in terms of an arteritic AION. And the visual loss is here due to CRVO or because of AION. In these cases, there's profound visual loss. RAPD is always present, and you see these ischemic changes, but classically is presence of thickened and tender temporal arteries. And treatment investigation would be elevated ESRs, high CRP, and temporal artery biopsy. Now, temporal artery biopsy is a gold standard, but in case you do not get it in one side, you can do it on the other side. If in doubt, you don't need to do the biopsy. You can start immediate treatment, which includes high-dose steroids. 50% will be reversed if you don't of the visual loss. If not, the other eye will also get involved in 60% cases. So this is one child who actually presented. She's around 14-year-old, which, as you see, that one eye is perfectly fine. The other eye had developed ischemic optic neuropathy. And when we investigated her, we saw this is an altitudinal defect. She actually had Takayasu arteritis. So, though commonly Takayasu arteritis, which is basically an inflammation of the large arteries, usually occurs in the form of either ocular ischemic syndrome or retinopathy, this patient actually presented as AION. Now coming to the other thing, I'll quickly brush upon the other things. This is a central retinal vein occlusion where the patient can have acute to subacute or partial and complete visual loss. Again, we'll have RAPD, visual defects are different, and if there is a macular involvement, then there is definitely loss of vision. Treatment would be to evaluate and find the cause of thrombosis and look out for long-term effects due to neovascular glaucoma. This is carotid cavernous fistula. Patients also present where there is an abnormal connection between the cavernous sinus and the carotid arterial system, which could be either direct or dural. In case of dural, they are basically low flow fistulas, and as you see here, and what you find is basically proptosis, dilated conjunctival and episcleral vessels, and classically dilated muscles, which you can pick up on B scan or on a CT scan. And this is what you're seeing is the dilated superior orbital vein, and these are what you have to look for. And then you can confirm it by a CT angiogram. Treatment will be basically, in case of low flow fistulas, will get closed on its own, but you may require to do an embolectomy otherwise for high flow fistulas. Then coming to this we all know is basically neuroretinitis, where you have an optic disc edema with macular exudates and vitreous cells. It is found to be a variant of optic neuritis, only that it never develops multiple sclerosis. So if you see a patient of optic neuritis and over 1 to 3 weeks, if it develops a macular scar, you can be relieved that this patient will not have MS. It could either be because of these infectious pathologies which need to be treated, or it could be idiopathic. Idiopathic we call as Leber's idiopathic stellate neuroretinitis, which is a self-limiting disease and should become okay by around 3 to 6 months. Finally, this papillopathy, which is a condition which is seen in young, healthy adults, where they also have an appearance of TIAs. It's something what we call as an impending CRVO. These patients do not have RAPD, but if you notice one eye, there's a dilated and tortuous veins. the other eye is fine. The vision usually doesn't drop, but we need to find out the cause and treat it. It is also called as big blind spot syndrome or optic disc vasculitis, the spontaneous recovery. But when we did an FFA, you notice that this filling did not happen till over 26 seconds. So then you need to study and find out the cause of what is the reason for this delay. And finally, traumatic optic neuropathy. Usually we see patients with optic disc swelling only if the injury has occurred anterior to the entry of central retinal veins. Eventually they develop optic atrophy and the vision would be very variable, the visual field defects. Treatment options, basically it's saying that 40 to 60% of these patients recover on its own, no need to do, spontaneous recovery occurs. And so no steroids to be given. However, if you need to give steroids, which has been discussed in the Cochrane review, can be given less than 8 hours of injury. Over 8 hours is actually not of much help. Regarding surgery as well, they have said that even if there is a direct injury, once the damage has happened, it's usually unlikely to recover. So not much improvement by doing, by trying to decompress the canal. Infiltrative optic neuropathy could be happen when there are basically in presence of primary tumors like optic glioma, hemangioma, etc., or secondary tumors related to leukemia. This patient has optic disc edema with bilateral involvement with leukemic retinopathy, and commonest cause in case of infection and inflammation is sarcoidosis. And finally, it's compressive optic neuropathy. In these cases like optic nerve sheath meningioma, intracorneal tumors, thyroid, you can develop a signs of optic disc edema. This is a patient, if you see carefully, there was opacification of the nerve fiber layer all around it, had an altitudinal defect. So we thought this was in a young girl of 20 years old. So we thought this was optic neuritis. But when we did the MRI scan, you would notice that there was a swelling at the border of the lateral rectus, which is basically a cysticercosis, which was compressing on the optic nerve. So basically, to conclude, a complete history, a thorough examination and appropriate tests will help in identifying almost all neuropathies by finding out their specific features. In a few cases, clinical cause will determine the diagnosis so as to make a differential diagnosis, like optic neuritis. If you feel and develops a macular star, this is neuroretinitis, etc. Diagnosis is usually clinical, and in certain cases an emergency like an AION. There are not too many options for treatment except in selected cases, and prognosis is highly variable. Thank you.